Good day, and welcome to Electric Light Waves webinar featuring Ciena, Digital Transformation for the Healthcare Market, Opportunities and Challenges for IT. Electric Light Wave, an Integra company, serves as a trusted network infrastructure partner to enterprises, government agencies, and carriers in select markets throughout the western United States. We've partnered with Ciena Corporation, the network specialists, to bring you an overview of how next-generation high-capacity fiber network can help you embrace telehealth. Before we get started, I want to review a couple quick housekeeping matters with everybody. The audio for this conference is streamed through your computer speakers, and if you're having any difficulties at all, please let us know through the Q&A window. We invite you to submit questions throughout the presentation by typing them in the Q&A window and hitting submit. All questions are private, and only the panel of speakers will see your questions. Any questions we don't get to during the webinar will be addressed offline following the event. And also, we please invite you to take advantage of the resources at the bottom of the console screen, where we've included some useful documents and information for your reference. And now, I'd like to introduce you to today's speaker, Daniele Loffreda. Daniele is a senior advisor for the Healthcare and SLED Industries for Ciena Corporation. He has more than 20 years of experience in helping organizations leverage information, communications, and technology solutions to better serve their constituents and improve their operations. For the past 10 years, he's led initiatives that enable the healthcare sector to integrate people, processes, and data in order to enhance the patient and provider experience and make their operations more efficient at a reduced cost. He's also a volunteer administrator at the Collin County Adult Clinic, where he's helping volunteer providers, nurses, and support staff transition to an EHR environment to serve the indigent population of the community. And now, without further delay, I'd like to turn the event over to you, Daniele.
Thanks, Joanna, and good morning, everyone. We are, for the next 45 to 50 minutes, going to take a journey, through health and health IT, and how the IT department is increasingly becoming more and more relevant in the whole patient value equation. We're going to start out talking about some of the key trends that are transforming the healthcare industry, along with digitization, security, privacy, mobility. Then we're going to talk about really what are some of the key issues that the decision makers in the health IT organization are having to grapple with, and how they're increasingly having to balance between deploying IT solutions that improve the customer or patient experience, while at the same time ensuring the security and privacy of the patient data. And we'll talk a little bit about what that means from a telecommunications network, and how do you align the network services and the architecture to address the advanced medical and healthcare applications. So first and foremost, we kind of take the macro view and say what's really going on in the industry, and what's driving some of the change. And the healthcare industry is one of the most dynamic industries out there. First and foremost, we're seeing just the continuation of the industry consolidations that we've seen over the last couple of years. If we think back in 2014, 100 deals were completed, 100 mergers and acquisitions, et cetera, completed in the healthcare industry, which was about a 14% increase from 2013. And just through the first 6 months of 2015, there's already been 50 or so of these deals, and so it kind of tells you by the end of 2015, it's likely to surpass the number of deals that occurred in 2014. Now, some of them are the big, huge deals, like the Anthem-Cigna announcement, which would recreate the largest health insurance company in the U.S. But more of them are the mid-sized to small deals. And the other kind of change from the last couple of years is that they're no longer just going through sort of the horizontal M&A. For example, in the past, it was more prevalent that larger hospital systems would acquire other hospital systems, sort of that horizontal approach. Now we're seeing a more vertical integration where hospitals are not just acquiring smaller hospitals, but also specialist medical practices. If we think that over the last few years, in year 2000, 1 in 20 healthcare specialists were actual hospital employees. Most of them were independent businesses. But in 2015, 1 in 4 specialists are now hospital employees. That's just showing how quickly the mergers and acquisitions are going towards a vertical integration rather than the horizontal. Now, I've seen a number of different reports, sometimes contradictory, that are trying to measure what's the impact of the consolidation on the industry in terms of the quality of the healthcare and the cost. Some are saying that it is these consolidations are really enabling a better efficiency and therefore extending a lower cost to the patient. Others are not so sure, and they're actually saying some studies are pointing to a decrease in the quality. But again, I think the jury is still out. Regardless, from an IT perspective, that really means that when all of these acquisitions and mergers occur, there's going to need to be some integration of systems and networks. A lot of these systems are disparate. Some are incompatible, some are redundant. To give an example, a customer project that we've worked off in the Florida market, when they integrated a couple of smaller hospitals into their system, they saw that each hospital had separate voice, data, and video networks, as did the company that was doing the acquiring. So they kind of took a look at the cost of that to maintain that, and whether the benefits were outweighing the cost, and they saw that they were able to pool and consolidate all of those networks, those disparate networks, into one single Ethernet network that was able to deliver a different class of service, so you could still have different classes and quality of services for your voice, your data, and your video, but you consolidate them onto a single network, and I think it decreased their costs something like $180,000 per year. So it not only gives them the bandwidth that they needed and simplified their operations, but also resulted in some costs. So it was beneficial for all around. Next, we kind of look at, and this is something that is going to be continuing over probably the next 5 years. It's an entirely new business model that is really coming to the fore. Whereas in the past, really the model was built around fee for service. The provider would bill for like the number of procedures they did, the number of visits they did. But there's a real movement being driven by the principal payers, the government and Medicare, as well as commercial insurance companies, to a more value-based model, where it's still fee for value, and where that value equation encompasses both the clinical outcome, was the patient healed, times the patient experience, often revealed by follow-up independent surveys, divided by cost. And we're seeing probably the movement began 2 or 3 years ago with some of the initiatives that were put out by Medicare. But if you look at the goals that just on the Medicare side is put out, by 2017, they're really looking for 30% of all payments to be in some sort of alternative payment model, not the fee for service model. And and they really haven't put out what those metrics really look like, but it can involve bundling of procedures, accountable care organizations, different types of strategies that they're banning and about. But by 2018, they're looking at 50% of all payments to be based on some sort of quality value-based model, and I believe they're looking at 2020, 2022 to have 100% of that. On the other side of the equation, there's the health insurance companies, and they're sort of following along. They're taking like a four sort of component category approach with narrowing the number of providers that will be allowed in their network, initiating value contracts, with those providers, a lot based upon the same sorts of models that the Medicare is looking at, and then tiering. They're sort of putting into place a method where they will offer different payment levels depending upon the acuteness of the condition and the duration of the condition. And this is all being enabled by big data and the data analytics. So this is really kind of shaking up the industry. Reports are saying that the industry is following along, but they're still really not seeing the full sort of embracement of this model. But they realize that they need to take those initial steps. And I think as of today, 53% of physicians still are reporting a totally fee-based sort of practice. Others are really kind of dipping their toe in the water and seeing how things follow along. But I think everyone realizes that train has already left the station, and they're going to really have to gear up for this. And they're really looking for specific guidance, and especially around the measurements and the metrics, and those are being developed, and they'll probably be driven out over the next year or so. So it's a really significant change that is really driving the transformation. One thing that we do know is that the penalties for not complying with this value-based model are in the increase. And I think I saw a report that's forecasting that 2,592 hospitals over the next 12 months are going to incur penalties of around $420 million just based upon patient readmission rates. So that's one of the quantitative metrics that have been put out, the patient readmission rates, and based upon poor performance. And I think the worst performers are going to they're losing like 3% of regular Medicare payments per year. And that's kind of manifesting itself on that forecast of $420 million of penalties just for patient readmission. So there's the carrot approach, where they're providing bonuses for those providers that embrace the value-based model and can demonstrate it. But I think it's really the stick, the penalties that are really going to move it along. Now we kind of look at what's going on based upon the Affordable Care Act. And, over the last 40 years or so, we've kind of had the traditional model of the providers, the hospital systems, the labs and the pharmacies, the insurance companies, and then the vendors like the biotech firms, the pharmacies, et cetera. Based upon the Affordable Care Act, and I think there's something like 10 million new patients coming into the system that providers need to compete for. That's attracting a lot of new sort of non-traditional entrants, and that's really because no single organization right now has the requisite competencies needed to support that continuum of care. And so these new entrants in the model is really driving more collaboration with the consumer, at the center of that healthcare model, the patient. Some examples up in Canada, Sanofi Pharmaceuticals is partnering with a telecom company named TELUS to launch a web-based private platform that offers patients self-management and monitoring tools. In Brazil, another telecom provider, Telefónica, acquired a controlling share in a Brazilian chronic care management provider named AccessMed. And then, here in the U.S., I think we've seen last month the announcement that IBM partnering with CVS Pharmacy to combine the power of IBM's Watson supercomputer with CVS's database of prescriptions and patient history to actually forecast, with the data analytics that I talked about before, forecast the health condition of patients 15 and 20 years into the future, and then develop preventative strategies for the patients to help avoid them. So just showing from telehealth types of companies to consumer education, connectors, and data analytics, there are not a lot new entrants that are entering the industry, and they need to figure out how they can work with the traditional players in the industry to embrace this new model and support it. Next piece is really the digitization of the healthcare sector, and it's really based upon sort of four key categories of digitization. The first is in the integration or the interaction of the provider with the patient, where the coordination of that patient's care is really run by over mobile devices, smartphones, iPads, that sort of thing. We're seeing in this the Pricewaterhouse Health Research Institute research that 79% of physicians are now reporting that they are their mobile phones will really help them to be more effective in coordinating their care, interacting with the patient, engaging with the patient, as well as the other specialists and physicians and labs that will be a part of that patient's health management. Actually, I think 50% of physicians are now saying that video visits over a device, whether it's in the home or over a smartphone, could become the primary means for the initial contact. So, not having to go into the office, into a hospital, but actually, using your smartphone or your iPad or your computer for that initial visit. The second piece is a more growing acceptance of do-it-yourself services. And again, this is, as patients become more responsible, for their own, the management of their health and wellness, they're demanding more sort of do-it-yourself services and more do-it-yourself devices are coming onto the market. And we're seeing that physicians are becoming more comfortable relying upon the results of do-it-yourself devices. And again, right now it's primarily for relatively simple procedures like monitoring vital signs. I think that's like 42% of physicians are comfortable with that. But they're also starting to embrace more sophisticated monitoring techniques such as like urinalysis, and then to a lesser extent, something like an ear infection, relying upon the results of that do-it-yourself device to prescribe medicine or prescribe something based upon the diagnosis. And again, there's got to be some trust in there. They have to really be sure that the patient is doing it right, and there's got to be some history to make them more comfortable with that. But there is this growing acceptance of that. The other piece is in data sharing, and we'll talk about that in a couple of slides. But both patients and physicians are becoming more comfortable with sharing that patient's data, not just internal to their system, but actually outside of their system. And it's becoming, it's a necessity in the case of a complex patient that has multiple conditions and maybe seeing different specialists and being treated through different labs and the facilities, that it's imperative that patients' data is being able to be shared amongst all those stakeholders, even if they're outside of each other's respective system. And that's becoming increasingly a requirement of meaningful use compliance, meaningful use 2, as well as getting ready for meaning use 3. And then, finally, the mobile apps. I think right now there's something like 165,000 apps out there dealing with health and wellness. About a quarter of them are now focused on disease and treatment, and 2/3 are still in fitness and wellness, but a growing percentage is really looking at more complex disease and more complex treatments. And I mentioned before, this is one area that the IT and the CIO sort of organization is really finding themselves trying to straddle two key areas. One is to really help that equation of increasing the outcome, quality of the outcome, the quality of the customer experience, and reducing the cost, and really using digital technology to reduce the gap in time and distance between the patient and the provider. So really trying to use IT to do that on the one hand. On the other hand, there's each device, each new person that has to view the patient's data, it raises security and privacy concerns. And so the IT department is sort of caught in the middle, trying to balance between the demand for the patients to be treated more like a retail type of customer and increasingly strict HIPAA compliance. I know I was at a conference a few months ago where the director of Department of Health and Human Services Office of Civil Rights, which is the HIPAA enforcement arm, she got up there and she was saying, if she had her choice, there would be no do-it-yourself or mobile devices. It's not compatible with data security, according to her. But she does acknowledge that that's the movement in the marketplace, and the onus is on the covered entity, which we'll talk about in a bit, the healthcare provider, to ensure that if they do enable mobility, if they do enable do-it-yourself devices, that they've taken the necessary requisite steps to ensure the privacy and the security of the data. We're also seeing the evolving boundaries of healthcare delivery, and I mentioned this in the previous slide. Consumers today want their medical services to really mirror the ease of the other sort of business-to-consumer types of models that we see out there with banking, retail, transportation, and others. And, in the healthcare industry, this manifests in, hey, they want immediate access to their test results, the images, any follow-up from the provider. They want it immediately and often on their mobile device. They want to be able to go on to a physician portal and have an interactive, real-time experience. And they're increasingly not satisfied with any delay. And, this is because they're becoming more active in their condition management. They have more choices in which provider to go to, and they have, more responsibility from a payment perspective as, the insurance companies and their employers, start to pull back a bit. So this is really saying that, the driving more towards a virtual care model and quickly replacing of the traditional models of having to go in for a physical visit each time. And this is especially for the initial visits and routine diagnosis types of things. And this is also an area where analytics really come into play to help the provider really identify and understand when a patient really does need to be there, in person physically versus when they can be dealt with via the virtual technology. So really, this tells that the IT department is really expected to fill the gaps between the consumer expectation and the current medical infrastructure. But we're also seeing that a lot of providers and hospital systems are adopting more sort of customer relationship management types of systems, similar to what the retail and other business-to-consumer models are embracing. And I think Salesforce.com is working to develop healthcare-specific applications, to really help the provider and the hospital system really improve the quality of their customer relationship management. The other piece that I talked about before is that the more data that is gathered from these end devices and then put into the electronic health records, increasingly has to be shared by more and more people, and that's just because the digital healthcare generates massive amounts of shared data. And I think those of you are on the phone that are the healthcare providers. October 1st was sort of the drop deadline for adoption of ICD-10. And if you look at ICD-10 versus ICD-9, ICD-9 had something like 18,000 code records. With ICD-10, you've got over 60,000. So that is really generating that much more data, and that's in addition to the more advanced types of medical treatments like the PACS and the digital imaging that we'll talk about in a bit. But it's just showing that in addition to generating that data, it has to be shared increasingly outside of the provider's immediate system. And we see here the range of health care stakeholders that are currently sharing data. I mean, it ranges from 87% with physicians, down to something like 8% with the public health. And part of this is because of the HIPAA requirements. I know that there's been a number of state health organizations that have been hit with some pretty significant HIPAA fines, so that might be one of the reasons that they are more reluctant to share data outside of their ecosystem. But as I mentioned, in complex patient care, and that's really less than 5% of the population, but it accounts for 20% of the healthcare spend. Data does need to be shared among multiple specialists, labs, therapists, the different stakeholders you see here, and especially with meaningful use too, and with where they're trying to go with health information exchanges, it's increasingly a requisite that the data be able to be shared. And that's driven some conversations at the industry, top of industry and associations and in the legislatures. Is it time to reevaluate the current HIPAA framework? Because that was really developed back in 2009 in a different area. That was before the proliferation of data, of electronic health records and health information exchanges that really pushed the boundary on who has to see the data. So I think there's a growing debate whether they need to reevaluate the HIPAA framework. At the same time, as we'll see in a couple of slides, I think the Office of Civil Rights, the enforcement arm, is actually going to become more strict, and that's based upon the Government Accountability Office report that kind of chastised them for not being as diligent in their audits and their enforcement. So I think we're going to see a lot more aggressive enforcement coming up. So I think there's going to be continuing conversations about what they do with the current HIPAA requirements. Some examples of the explosion of patient care data, and this is as different procedures become more commonplace and increasingly need to be have that ability or capability because of competitive pressure. But if you look at high resolution image files, they're probably one of the biggest bandwidth consumers that we've seen. If you look at just one single instance of a full body PET scan, and we say just one image of a PET scan is looking at 600 megabytes, and you're looking at the size of one set, 1.2 gig, and the number of sets typical with each one sort of patient in 4. So just the exam file size for one person at that particular time is 4.8 gig, and then you kind of look at full MRI, going up into the 320 gig. So from a health system perspective, you got to kind of look at what's my imaging department doing, and how often throughout the day do they do these different procedures, and what's the duration and how many images per set on average, and that sort of tells them what sort of bandwidth needs they require. Then you look at something like genome sequencing, and you're just off the charts, in terms of the amount of bandwidth that you need. And then you kind of look at, we talked about before with video, replacing physical visits, and you're just looking at the amount of bandwidth that you need, depending upon high definition video, versus 4K, and that's just showing you how much more bandwidth you need in your system, and then you have to times that by the number of those types of activities or procedures that are done on a daily basis. I know again a number of one of our other customers that was going through the same sort of thing. They actually were doing pretty good with a full 1 gig network, but as they absorbed some some smaller systems and increased their imaging capability and deployed more video diagnostics capabilities, they quickly saw that they needed to up their bandwidth, and I think they deployed a 10 gig network throughout their system, which ensures them that they've got all the bandwidth they need. But the way they configured it and the architecture, they actually reduced their total monthly cost, and that quickly I think it on their return on investment, that was something like 11 months to get to recoup their investment. So they were able to provide their systems and their physicians and their departments with all the bandwidth they need for these type of advanced applications, and actually reduce their cost. And so again, the need to share more information outside of the system, it really kind of shows the evolution from paper, which again, in my experience with the Collin County Clinic, up until about last year, we were pretty much still a paper-based operation with files, stacked floor to ceiling. Over the last year, we've seen this evolution to the electronic health records, electronic medical records, and for the most part, right now, they're pretty ubiquitous across the U.S. I think something like, there's nearly full adoption in the U.S. of EHR systems, but again, there are different EHR systems and different levels. And I think what we've seen with the shift to ICD-10, a lot of providers are scrambling, to make sure that their EHR systems can accommodate the new the additional codes of ICD-10. But so I mentioned they're pretty ubiquitous adoption, but the expected benefits, according to the reports, have really sort of proven elusive, and that's really because the focus has been mostly on the technical aspects of being able to comply with meaningful use, but they need to adjust, and this is putting additional pressure on CIO to the new value-based model to make that link between the electronic health records and the value-based model. I think something like 41% of hospitals nationwide, they're reporting that they've got routine electronic access to the necessary clinical information from outside providers. But that means 59% of them are not. So a big area for trying to push towards the health information exchanges. And I think something like less than half of all hospitals are able to integrate the data they receive from outside of their system into an individual's electronic health records because of the interoperability issues. And I think now it's driving, along with the High-Tech Act of 2010, the implementation of health information exchanges. And I think something like 84% of states report that they have at least one HIE. And you've got sort of two variations of health information exchange. One is the query model, where the provider has to log in to access any updated EHR record. The problem with a lot of that, and they are the most common and probably the least expensive, but the physician's often not aware that the EHR has been updated, and or they don't check. And so they sort of developed a push model, which really puts the EHR updated information directly into the physician's system, or notifies them somehow by an email. But again, in that instance, the problem is they have to get out of that and log back into the EHR system to see that. The other piece that we've seen that kind of has been hindering the embracement of and success of health information exchanges is that I think something like only less than 10%, I think 9.4% of all health information exchanges support all 8 core meaningful use 2 criteria. So again, until they can fix that, it's probably not really going to do anything for the embracement. And as I mentioned before, the interoperability issues persist, especially when you're dealing with complex patients that have multiple providers. And so, that's kind of spurred the Office of the National Coordinator, who's really responsible for driving EHR and HIE adoption. They've just released, I think it was like last week, their shared nationwide interoperability roadmap, and that provides directives and recommendations on addressing the issues and timelines in order to meet their, and this is the ONC, their 2021 to 2024 vision of nationwide interoperability. So there's, that's telling us that over the next, 5 to 6 years, there's going to be, some significant attention and focus put on these interoperability issues. So the other piece is that there's a sort of changing attitudes, towards the cloud model. If you would have, kind of checked back over the last few years, we would have seen a rush to public cloud providers that promised, greater performance and lower cost. And indeed, I think there was a HIMSS and a Dell survey that reported over 80% of their respondents, were currently using or considering using a public cloud service. But now, over the last couple of years, there's really been 2 schools of thought that have evolved. One is, those health systems that are embracing public cloud. I think I saw an example of Beth Israel Hospital doing a proof of concept, moving their electronic health records system over to Amazon's AWS systems. And that's because they're saying, hey, the volume of our data is growing an average of 20% per year annually over the past 5 years, and we're now at 4 petabytes, and that's just really inhibiting our ability to move this data around to all the people that need to see it. So we're really looking at the cloud environment. The other school of thought, and it's exemplified by a statement I saw from UC Irvine's Medical Center, saying, hey, we have no plans right now to use a public cloud because it's not entirely clear that these cloud providers have policies and procedures in place to support the unique needs of the healthcare industry. And I was at the Health Technology Summit a few months ago. We were actually a sponsor of the cloud panel. I was a moderator, and the panel participants, there were 4 or 5 directors, VPs, CIOs from healthcare systems across the country, and one of the key questions that they were discussing was, has the model changed over the last few years, where maybe 4 years ago the public cloud, that model really supported what we need, but is that still valid in today's environment, especially because a number of cloud providers are refusing to complete business associate agreements, and we'll talk about what that means here from a HIPAA compliance perspective, but they're not willing to sign business associate agreements that bind them to HIPAA compliance and include indemnification to the covered entity if a breach occurs. So there was a lot of discussion at that panel meeting. They're really saying, hey, should we look at a different model, and should it be more of a hybrid model where for mission critical applications, we build sort of a private cloud model, and we may have to go to some of the stakeholders outside of our system that we deal with the most, and everyone kind of combine together and build this private system. And then for non-essential types of things, say we can still go with a private cloud. But there's a lot of discussion now, and one of the key points, one key questions that came out of that whole panel discussion, and it was addressed to the 35 or 40 audience members, were, do you have an exit strategy from your current cloud provider? in the event of you get acquired or you get a new boss, new CIO, what is your exit strategy, from your current cloud provider? So it's kind of interesting. The cloud providers, in their turn, they're sort of feeling the pressure, and they're starting to say, okay, we need to step up to the requirements of HIPAA and sign, business associate agreements. We're encrypting the data both at rest and at motion, for our clients, and we're deploying that multi-layered security architecture that will, pass a HIPAA audit. So it should be interesting to see which happens first. Does everyone move away from the public cloud, or do the public cloud providers step up and really accommodate the unique needs of the healthcare industry? And that sort of leads us to this whole discussion, and this is really brought about because HIPAA data breaches have increased by 138% since 2012, and they've done a study, and they showed that a healthcare record, they kind of combined healthcare records with banking records and with retail records and all, but the healthcare record is worth to an identity thief 3 to 5 times more than like a retail type of record, and that's just because of all the detail that you have to provide when you first go in and begin a relationship with a provider or enter into a hospital system. Just the amount of personal data that you have to complete is very valuable to an identity thief, and so we've seen with the HITECH Act of 2010, sort of expanded the HIPAA compliance requirements to include the business associates and their subcontractors. And prior to 2013, HIPAA really didn't have a lot of teeth, but now the Office of Civil Rights of the Health and Human Services Department have really been given the teeth, i.e. penalties, to really enforce that. And then so you have to think if you're a covered entity, and that had been the primary entity responsible for HIPAA compliance, now you have to engage in business associate agreements with any vendor that touches your patient's information. They call protected health information, and that could range from an accountant, to your webmaster, if they touch frequently protected health information. They've also seen, the majority of the HIPAA security rule violations are due to inadequate policies and procedures safeguarding electronic protected health information. A lot of that is due to lost or stolen devices like laptops, smartphones, thumb drives, that sort of thing. But a big enough percentage is really focused now on the data once it leaves the environments of your security perimeter. And that's really where we're seeing this data in transit is so key right now. And if you kind of looked at what's the impact of a data breach, right now between penalties, the cost of notification, brand impact, having to remedy the breach, on average, it's getting towards like $3.8 million. But that doesn't take into consideration the amount of churn of patients away from the most egregious data breach victims. But the HIPAA requirements do allow you one sort of safe harbor, and that is saying if your data is encrypted, whether it's data at rest or data in motion, it's encrypted according to the NIST guidelines. You don't have to report the data breach, which is significant, because if you think you've got to report a data breach regardless of the number of records, but if the number of records impacted is over 500, that's when all the real penalties and cost start to kick in. So if we look at what are the major reasons for these data breaches, and a lot of providers and CISOs spend a lot of money on putting policies and procedures in place, but they will admit the number one reason for these data breaches if they're unable to enforce compliance. So that tells you why you really need to focus on data in motion rather than just policies and procedures. You can't ignore policies and procedures. You can't ignore perimeter security, but you have to focus on data in motion. So now we kind of go along, aligning network services to the sector needs, and we kind of look at, what are the key challenges that the CIO is facing, and we kind of talked about those before, having to balance between providing the customer experience, the ease of use, the mobility, with the balancing against the privacy and security issues that I just talked about, and then ensuring that there's bandwidth for all the advanced medical procedures that will enable that system to remain competitive in an increasingly competitive marketplace. Making sure that they're able to comply with meaningful use 2 and start to really understand meaningful use 3, because that's coming up in 2017. Trying to ensure that they comply with ICD-10 and that the stakeholders that they deal with are also compliant with ICD-10. And I know that there are 5 states, 2 of them, I think one is California and Montana, in that western area, are saying that they're not ready for ICD-10. So the healthcare providers have to be able to have systems that are flexible enough to still deal with some sort of hybrid between ICD-9 and 10, and demonstrate from a federal perspective that they can support ICD-10. So a lot of sort of contradictory challenges that they're looking at. But this is where the network comes into play, and we're really talking about ether packet, optical, Ethernet, wavelength types of services that can really enable all of these advanced healthcare applications and really provide that key connectivity between the intelligent device and mobility that accesses and gathers the patient data and the big data analytics in the cloud that really have to perform the predictive types of measurements. Without that, that robust network, none of that will connect. And I think we've seen studies that show 7.2% lower mortality rates in the most wired hospitals. Another system that we've worked with said that by deploying their advanced wavelength and packet network, they were able to actually trace a 40% reduction in emergency room mortality rates, based upon the in emergency room video monitoring capabilities that they put in, which was enabled by this robust network. And we're sort of looking at some of the examples of why that the bandwidth needs have increased so much. You can kind of look down the left-hand screen. You see the different types of modalities, ranging from the EKGs, all the way down to the fluoroscopies and the nuclear medicines, and they show you the average exam size. And on the right-hand side, it shows you the amount of time it takes to download, the largest sort of file size, depending upon what type of bandwidth you have, and you're ranging from T1 to 100 meg. If you put a 1 gig or 10 gig, you're talking about 5 seconds. And if you think, if you're trying to improve the customer or patient experience and keep the providers happy, no one's going to stand by and wait for 30 minutes, to see the results of that test. They want to see something, in really less than 10 seconds. So that just tells you the type of bandwidth you need. We're also talking about the picture archiving and the communication system, and this is really as we move toward the more video environment, this is becoming more and more important. If you see, everything sort of starts at where you access the images, and that's really in sort of the radiology, the surgery theater, where that live sort of video stream has to come in, and depending upon who is actually seeing that and when, could range from a remote heart specialist videoing in from another part of the country or another country that has to be able to see that 3D image live, and it could range all on the other side of the spectrum to just someone in an insurance company that can can archive or log in and see the archive of that image, days later. So it's really, depending upon where the viewer is and at what time, tells you what type of bandwidth you need. So obviously, from someone videoing in live, that needs to participate, they need to have the highest level of bandwidth with the lowest amount of latency and jitter, because it's life and death, versus someone that's just a receptionist or a clerk that it can access it days later. Another sort of evolving application is in the electronic prescribing, and I know that from a personal experience at the clinic, the EHR system that we have does not allow the physicians to include a prescription. They still have to fill out a manual prescription. And if you look at the different hospital sizes, being able to access the records of someone's prescription, especially in an emergency situation, it saves them time and cost versus having to look through manual records or do a manual search. And it can range anywhere from $110,000 per year from a 100-bed hospital all the way up to $1.1 million per year for a larger hospital. And what does that tell you? It requires pretty significant bandwidth, to be able to connect into those systems. And again, that talks about the importance of interoperability in the health information exchange system, where something like this capability would also have to reside. The other piece is advanced telehealth applications, telesurgery. I had a CIO tell us that unless you've got a robust telehealth, telesurgery, and a robotic surgery capability, you're not going to be able to compete in 5 years. So I think telesurgery, where telesurgery and robotic surgery, where the robot and the physician or the surgeon are in the same room is getting more commonplace. What the application, what they're really looking at, and this is really just in the research stage now, is saying if the robot is in the surgery room and I've got enough bandwidth that can guarantee me low latency and low jitter, can I have the surgeon who may be in another town or another area of town, could I have them log in and manipulate that robot's arm from wherever remote location they are and still guarantee the success of the surgery? So that's something coming in the future, and because if you look at the cost of having to bring a surgeon over from a different part of town, different part of the country, different part of the world, and you're looking at how you can reduce that cost and even improve the quality, robotic surgery, remote robotic surgery is something that they're looking at for the future. And this, again, tells the importance of that optical Ethernet type of network. A lot of our customers have said, do I need that level of bandwidth for all of my applications in all of my areas? And you're kind of looking at, whenever you're looking at like a 1 gig or above type of bandwidth, that's where the cost effectiveness as well as the throughput levels of an Ethernet and optical-based service, it really start to shine. So if you look at anything from like below 1 gig, you can look at a level 3 or a level 2 type of solution. But once you get into the 1 gig and above, that really lends itself to an Ethernet or an optical type of service, especially if you look at the need to add encryption on top of all your records. I think they've done a study where they said, a 1 gig type of service or application with encryption, and they looked at the actual throughput on a level 3 sort of MPLS type of service versus an Ethernet type of service, and they showed that with the encryption, the actual throughput of the MPLS solution reduced to about 800 meg, but you're still paying for the 1 gig, and the addition of the encryption, added on that latency. If you looked at the Ethernet service, the 1 gig that you paid for is the 1 gig that you got. So that the addition of the encryption, didn't impact the throughput. So again, if you're looking at, where do I deploy these large, bandwidth types of services? If you're just looking, small location to small location, probably doesn't lend itself well. But if you're looking, location, into the regional headquarters or into a data center, then you're looking at like 1 gig type of service. And certainly, data center to data center, you're looking at, the 1 to 10 gig and above types of levels. So if you're looking at where I architect, my network, that's a good guideline. So kind of key takeaways, and I know we've kind of gone over this very fast. Healthcare is now a digital business. It's file-based, and you really need that network to provide the information access, the connection between the access of the information and all the stakeholders who have to see it. Over the next 5 years, it's going to be critical to link the data generated by the new technologies and all the different providers with all the stakeholders that have to now be involved in the patient's care, but really integrate it into an everyday practice. And it's increasing adoption of health information exchanges and more sophisticated levels of electronic health records. And then connectivity and advanced services increase the access to the care. Again, we're looking at that value-based business model calculation. It helps improve the quality of the care, improves the customer experience, and it reduces the cost of that care. And again, that's really based upon a robust broadband type of network. Joanne, that is all that I have got to share today. Do we want to move into some questions?
Yeah, excellent. Thank you so much, Daniele. We do have a few minutes here left to jump into a few of the questions. I just want to remind people quickly, you can type your questions in the Q&A window and hit submit. And any questions we don't get to during this session, we'll be sure to follow up with folks after the event. I see we have a few in here, so why don't we go ahead and get started with what we can.
Let's see. Could you read them? I'm not seeing them. Could you read them?
Sure. Yeah, let me just dive in here. I think we probably have time to get to a couple of these here. First one is, we're considering providing a guest Wi-Fi network for patients at our clinic. What are any recommendations you might have to keep it secure and prevent guests who use this network from accessing private patient data?
Yeah, I mean, that is a common question. And again, it's that balance between providing the improved, customer experience, patient experience, and the people who come with them, with the security. So what a lot of systems that we've worked with say, if you're going to deploy a Wi-Fi sort of service, you want to make sure that it's you keep it outside of the hospital system's firewall and security perimeter, and that you only provide it for internet access. You don't allow them to access any of the hospital systems behind the firewall. Now, again, if it's a patient and they're trying to access their records, you need to make sure that you've got the authentication and authorization that is compatible with a Wi-Fi type of network. But generally, you want to keep any kind of Wi-Fi network outside the firewall.
Okay, great. We've got another one here. Do you predict HIE's use to increase, and how are their growth trends compared to EMR and EHR?
Sure. So again, they're not separate. EHRs, EMRs, and HIEs are they're all sort of related. And as I mentioned before, the Office of the National Coordinator's got their roadmap. That really says by 2022 to 2024, they want this full nationwide capability that allows full access and transmission of a patient's electronic health record, and with the addition of, for example, the ICD-10 additional codes, accessible to everyone. And so I think that's pretty much putting a stake in the ground, seeing by 2024, these HIEs will have all the interoperability issues resolved, and the financial sustainability issues addressed. I know I mentioned before, I think 84% of states report having at least one HIE. Most of those are state or public run, and I think 74% of those have run into financial difficulties. So, there's interoperability and financial issues that have to be addressed, as well as expanding their capabilities to address all of the core criteria of meaningful use 2, as well as the meaningful use 3 that's coming up in 2017.
Excellent. Yeah, thanks so much, Daniele. It looks like we're right around the top of the hour. Do you have any final closing remarks before we sign off?
No. Again, I thank for everyone for their attention. Obviously, healthcare is changing every day. It's difficult to keep abreast of all of those changes and align them or link them to the things that are most critical to you. I really do thank Electric Lightwave for sponsoring this. As I said, this is a dynamically evolving sector, and I really give kudos to Electric Lightwave for making this information available to their customers.
Excellent. Thank you so much, Daniele. And thank you also to everybody who joined us today. This now concludes our webinar, Digital Transformation for the Healthcare Market, Opportunities and Challenges for IT. We'd ask if you could please take a moment to fill out our post-event survey. It'd be really great because your feedback is very important to us to make sure that we deliver the most informative webinars possible. Thanks again, and have a great day.